Okay. Okay, I guess I'm audible to all.
Yes, sir.
Okay, fine. So we'll start. We were talking about myasthenia gravis, and now that we already are aware about what is the condition, how it is, we are going to see in a bit detail about the symptoms and classification of the disease through the myasthenia. So we had already talked about what is myasthenia gravis. So it is either autoimmune or congenital neuromuscular disease that leads to fluctuating muscle weakness and fatigue. So the main problem in myasthenia gravis is more specifically to talk about antibodies immune system forming against the receptors where the acetylcholine binds and creates action potential. The acetylcholine binds in action potential generate per se એ receptors જ decrease થઈ જશે or they will be destructed by the immune system of the own body. We already talked about few of the symptoms: fatigability, susceptible muscles, muscles that control eye and eyelid movement, facial expression, chewing, talking, and swallowing. Onset is always sudden. The first symptoms will be related to the eyes, face, facial expressions, neck, and later on it can move even to the limbs. The degree of muscles which are involved varies very much. If it is starting, it will not be that severe, but later on it will become very severe. Asymmetrical process, diplopia, which are the two main things. And of course, the muscles of the neck will get involved. So the patient, you will see, will not be able to maintain a specific posture, specifically neck extensors and flexors. Either of them will become weak over time. Myasthenic crisis, something we talked about that immediately अचानक જ patient ने myasthenic crisis થાય, crisis as in emergency condition, and the patient will have paralysis of the respiratory muscles. If the patient is having paralysis of the respiratory muscles, there are chances he will need ventilatory support, and if not overhead, even he or she can die. The main reasons is stress, extreme heat, like Botox phenomenon in multiple sclerosis, infection, so systemic infection, viral upper respiratory tract infection, receiving general anesthesia, neuromuscular blocking agents, and pregnancy. Four possibilities or four theories which can explain as to what is the pathophysiology behind the myasthenia gravis. So first and important is autoimmune. That is widely accepted. Okay, it is an autoimmune disease through which this will progress, and later on it will lead to even death if respiratory muscles are involved. Immunological cross reaction with infective agents. So because of the infection, the body has formed some antibodies. These antibodies, because of the formation of antibodies, they start reacting to the neuromuscular junction and muscles receptors chest and destruct. Third is genetic, which is normally seen in congenital. These are the two main genes which are affected: HLA-88B8 and DR3. Abnormality of thymus. So thymus is also thought to be infected. This is the main action, mode of action, how it will be affected. And later on, you can see because of the destruction, it will be affected, and destruction leads to reduction in the number of receptors. Acetylcholine normal છે, vesicles normal છે, synapse normal છે, but post synaptically, muscle માં જ્યાં bind થવા જોઈએ acetylcholine, they will be reduced. So this is pathophysiology. After this, how do we diagnose? So the patient becomes easily fatigued. Yes, the patient becomes easily fatigued, and if you give rest, it will improve, but it will improve drastically. Again, if you do the same exercises, if you do the same muscle action that you asked initially, the patient will again become fatigued. Yes, so there is a decremental response also on the EMG as we explained yesterday. It can be furthermore divided if a patient is having from the small age, neonatal, congenital, and juvenile. Neonatal means from birth, within diagnosed within 2 or 3 days. And Only 12% of the pregnancies with mother will lead to this condition. If the mother has, then only 12% chances the baby will also have it. Mother will be better before or during the gestational period, but after the labor or after the delivery of the child, the mother's symptoms may get worse. While the child, in the first 2 days, there will be symptoms, later on, he or she will be normal. Congenital, mainly speaking, children of healthy mother can very rarely develop myasthenic symptoms beginning at the birth. So this is also termed as congenital myasthenic syndrome. If it persists from birth up to many years, this is congenital myasthenic syndrome. Like the same we discussed about the diagnosis also. And juvenile, that is occurring in the childhood, but after the peripartum, that is after 2 to 3 years. If it starts, the symptoms start, that is juvenile. We talked about that diagnosis of CMS, congenital myasthenic syndrome. So onset of symptom in infancy or childhood, yes, after the birth or within 1 or 2 years, if the symptoms appear, then we can say it is CMS. Weakness with increase as muscle tires, classical sign of myasthenia gravis. Decremental EMG response on low frequency of the compound muscle action potential. So you should remember it will always have a decremental EMG response. No anti-acetylcholine or the binding proteins of the receptors present, they will be negative. Yes, why they will be negative? Because it is not an autoimmune response. Body is not responding. It is something that is obtained from the mother itself. Yes. So there will be no anti-acetylcholine antibodies. No response to immunosuppression therapy. So immunity has not ectoderma. Congenital myasthenic syndrome, mother માંથી antibodies આવે, it is carried forward. Yes. So immune system ખુદ ની suppress કરવાથી antibodies ને કાઈ ફરક નહીં પડે. That is why no immunosuppression therapy will help. Family history of symptoms which resemble CMS. Yes. So if the mother or father or any other in the maybe other siblings also have such symptoms, then it is not going to be because of this CMS. Coming to classification, main aspect. Yes, so there are 5 classification and within 2, 3, and 4, again there are 2 further classification. It all depends on the involvement of the body part. Yes, which is the body part that is involved. So foundation of Myasthenia gravis and the foundation of American clinical classification has suggested class 1. Eye muscle weakness, possibly ptosis, no other evidence of muscle weakness elsewhere. Can muscle weakness may only eyes, that is termed as class 1. Class 2, eye muscle, severe or mild, with weakness of other muscles. Yes. So again, there are 2 further classifications of 2A and 2B, predominantly limb or axial muscles, and 2B, predominantly bulbar and respiratory muscles. Bulbar, whenever we speak the term bulbar, it is always related to lower 4 cranial nerves. Yes. So if limb or axial muscles, shoulder and hip specifically musculatures are affected at this time, we can say that it will be class 2A and 2B. 2B if there is respiratory muscle involvement and bulbar involvement. 3 again is classification related to eye muscle with any severity, moderate weakness of other muscle. 3A will be limb or axial muscles, so whole limbs start to develop weakness, and 3B predominantly bulbar and or respiratory muscles. Here, the only difference that we are encountering in 3 and 2 is eye muscle weakness of any severity and eye muscle weakness of any severity, but mild weakness of other muscles. Here, there will be moderate weakness. Yes, so the severity is more compared to class 2. Class 4, eye muscle weakness, any severity and severe weakness of other muscle, predominantly limb or axial 4A and 4B is predominantly bulbar and or respiratory muscle. Yes, so 2A, 2B, 3A, 3B, 4A, 4B are same. You just need to see the severity of the other muscle. Eye muscle weakness will be there. Along with that, limb muscle, if they are moderate, less involved, more involved, or severely involved. Depending on that, there will be class 2, 3, and 4. And class 5, the terminal stage, is where you have to require, the patient requires intubation to maintain the airway. So if they are not given airway ventilation, then there are chances the patient will not survive. Physically, now the patient is coming to you, neurophysician, yes, or a physical therapist. How will you test? How will you know? So looking upward and sideways for 30 seconds, pulses and diplopia you check for. Yes, so first of all, you ask the patient to look at a specific point for 30 seconds. As we know, eye muscle સૌથી પહેલા involve થાય છે અને severely પણ involve થઈ શકે છે. The patient will not be able to either maintain it or you will be able to see process and the patient will complain of diplopia. Yes, so three things you have to observe while the patient is looking upward, upwards, or sideways anyway. Second, looking at the feet by lying on the bed for 60 seconds. So whenever the patient is lying, at that time you ask the patient to flex their head and look at their feet. So fine patient and head flex કરીને એમના પગ જોવાના feet. Yes. If they are able to maintain this for about 60 seconds, then we can say the patient is not having severe involvement. If the patient withdraws this within 60 seconds, we can say the patient has moderate to severe involvement of neck muscles also. And we already saw neck muscles are one of the important muscles that are being affected. 10 deep, 10 deep knee bends. That is, you ask the patient to do squatting. Yes, so while doing the squatting, total knee bend. Yes, directly ઉઠક બેઠક આપણે કહેવાનું કરવાનું, but from the standing position to completely knee should be flexed. As much as possible, the patient has to go down. Walking, just a second. Okay, sorry. Fine. So looking, sorry, step and deep knee bend. So completely from standing position to completely knee bending position, squatting position up to the lowest portion. Yes. Then walk 30 steps on both toes and heels. Yes. So walking on toes, as we had already described in coordination, and walking on heels, 30 steps. Yes, that will also cause fatigue of the lower limb muscles. 5 sit-ups, lying down and sitting up again. Yes, so 5 sit-ups the patient has to do, then lie down for 5 and again sitting up completely. So this will also give you a response that the patient is having a feeling of fatigue or not. And lying down in between we are giving so that there is relaxation, there is a phase of recovery. And again, when we do the same thing, it will be because the patient has less amount of acetylcholine in the synapse, or we can say receptors are decreased. At that time, the patient will feel fatigue again. We can also confirm the same by blood test. Serology can be performed. Specifically, musk protein antibodies. Musk protein antibodies are nothing else but antibodies present related to the neuromuscular junction. If I have to be specific, they are also termed as muscle specific, tyrosine kinase. Yes, so that is what the name of the protein is. In specific situation, testing is performed for Lambert-Eaton syndrome. Yes. Lambert-Eaton syndrome is again a neuromuscular disease. Understand the difference, it is much more important. Here, the number of acetylcholine vesicles decrease. Acetylcholine vesicles क्या होय? Neuromuscular junction होय तो nerves માં થશે. These decrease એટલે કે acetylcholine જ ઓછા છે, and because of this, the receptors are normal at the post-synaptic level, but the acetylcholine itself is limited. Okay, let me just. Okay, so they say this is the nerve and say this is the muscle. Now, the nerve will get impulse, and because of this, this will be the synapse. Here, the vesicles are already there filled with acetylcholine. Acetylcholine will be released in the synapse, which will bind with the receptors. Yes, at the other end of the neuromuscular junction. Now, in what we are discussing right now is myasthenia gravis. In myasthenia gravis, most important thing is this receptors. They itself get reduced. Yes. So if these receptors are reduced, what will happen? Acetylcholine is enough. Say for example, 100 acetylcholine are there, but they will not have enough space to bind to this portion. Yes. Now, if we talk about Lambert-Eaton syndrome, This Lambert-Eaton syndrome means these vesicles that are filled with acetylcholine, they decrease in number. Yes. So this is pre-synaptic disease. Receptors are normal. Enough amount my receptors share. Yes, more than enough they are there. But acetylcholine number, say for example, out of 100, it has decreased to 50. So it has decreased. So here it will lead to less number of acetylcholine binding to receptors. Yes, gonna be the receptors and then so that will again lead to decreased action potential. Decreased action potential or decreased threshold will lead to no contraction of the muscle directly. So that is Lambert-Eaton syndrome. It is a presynaptic. And myasthenia gravis, it is postsynaptic. That is the main difference. Yes, I hope everyone is clear about this now. Okay. So, as we talk about Lambert-Eaton syndrome, in which antibodies against a voltage-gated calcium channel can be found. So, that is more of something that we find in Lambert-Eaton syndrome, but not in myasthenia gravis. Electrodiagnosis can be done very easily through RNS and surface EMG, SF-EMG. Yes, so it can be easily done with RNS, repetitive nerve stimulation, and surface EMG. After this, there are other tests also. One of them is ice test. Applying ice to weak muscle group characteristically leads to improvement in strength of those muscles applying the ice for 5 minutes. So whenever you are applying the ice for 5 minutes continuously, what will happen? It will lead to decrease in acetylcholine esterase level. Okay. Now we talk about just few acetylcholine. Say for example, this acetylcholine from the vesicle has been released. Yes, and it will lead to transfer of signal to muscle. Yes, which will cause action potential, increase in muscle permeability, sensitivity, and lead to electrical impulse formation. Now we see this acetylcholine once it has binded, then what will happen? एक बार acetylcholine bind થઈ ગયું, then it will be released again in the synapse. From the synapse, it will be converted to or broken down by acetylcholine esterase. As the name suggests, it is an enzyme. Acetylcholine esterase enzyme શું કરશે? આને breakdown કરીને પાછું nerve પાસે મોકલી દેશે. Again, the nerve will form a new vesicle with new acetylcholine, and when again impulses come, it will transfer this acetylcholine to the synapse, and again it will cause binding with another protein or another receptor. Yes, this cycle continuously goes on. So if acetylcholine esterase, now as you know, you might have studied in biochemistry, acetylcholine esterase or any enzyme works something that we call as optimal temperature. If there is no optimal temperature, then the enzyme will not work. Yes, so by providing icing, we are changing the optimal temperature. Yes, એટલે કે enzyme action stop થઈ જશે. So what will happen because of this? Acetylcholine esterase continuously under રહેવું, receptors are decreased. Yes, base receptors છે 10 acetylcholine છે. Yes, so what will happen? If esterase is there, breakdown થઈ જશે આનું. Yes, this will directly lead to breakdown. The 10 માંથી say for example 5 થઈ ગયા, એટલે કે 2 થશે, 2 they will bind here. Rest 8 માંથી 3 તો એમને esterase જ ખાઈ લેશે and will send it back to the nerve. Yes, so if we prevent this esterase, 10 માંથી 2 utilize થયા, તો this 8 will remain there only. Yes, so જેમ space ખાલી થશે એ પાછા bind કરવા માંડશે with the same intensity. Again and again it will cause binding. Yes, so to prevent esterase is one of the things we provide as a treatment for myasthenia gravis. Myasthenia gravis માં આપણે એ જ ટ્રાય કરીએ કે acetylcholine esterase ને મિનિમમ રાખીએ સિનેપ્સ માં, એટલે કે acetylcholine breakdown નહીં થાય. Acetylcholine breakdown નહીં થાય એટલે it can easily bind again and again to the same receptor. Yes. રિસેપ્ટર ઉપર બાઇન્ડ થશે એસિટાઇલ કોલાઇન એનું કામ પતી ગયું અહીંયાથી ડિટેચ થઈ જશે બીજું એસિટાઇલ કોલાઇન ને પાછું બાઇન્ડ થઈ શકે for that reason we are preventing acetyl choline esterase to be present in the synapse. Just a second. Yes, so that was about, then comes the electrodiagnosis as we described, and this was the ice test. So for applying ice for 5 minutes to any muscle, we need to acetylcholine esterase inhibition at lower temperature because it is an enzyme. So it is one of the diagnostic tests. Now this is ice test that can be easily seen. You see the eyes of an individual. Yes, you see the difference here. This will tell you that there was process, and here the patient does not have unilateral, it will be bilateral involvement. And you can see the eye opening now. Ptosis is something that we call decrease in the opening or closing of the eyelid. Yes, so that by applying the ice directly over the eyes, muscles of the eyes, extraocular muscles, you can see there is improvement. Also, this is the sleep test. So from the sleep test, you can make it out that the patient, when lying supine down and asked to look at their feet, there will be neck flexion, and because of this neck flexion, continuously if they can hold it for 60 seconds, then it will be normal. If not, it is abnormal or the muscles are involved. Now comes to important androphonium test. Androphonium is a class of drugs that we used to prevent the breakdown of acetylcholine. Yes, the important terms that you have to remember is androphonium chloride and neostigmine. Yes, both these terms are most important when you're writing the medical management of myasthenia gravis. So, intravenous administration, IV, administration of androphonium chloride or neostigmine drugs that block the breakdown of acetylcholine by cocholine esterase and temporarily increase the level of acetylcholine at the neuromuscular junction, that is synapse. Synapse માં directly in level વધી જશે because we are not allowing the degradation of acetylcholine. In people with myasthenia gravis involving the eye muscle, androphonium chloride will briefly reduce the weakness. So, even in myasthenic crisis, as we have described, yes, here also androphonium is the choice of drug for emergency conditions. This is again the same thing. This is androphonium test. You can see the administration directly of the IV androphonium can lead to relieving of the symptoms. See the opening of the eyes. Diagnostic test sensitivity. Now, once we have to diagnose, we have seen the symptoms. Now we have to confirm it. Yes, this is only myasthenia and not any other symptom or disease. So, first and most important in acetylcholine receptor antibodies. Why it is an autoimmune disorder? Autoimmune disorder છે એટલે એના against antibodies form થશે. તો blood માં directly if you see, then there are chances you will find it in ocular and generalized. In ocular, there are 50% chance. In generalized, it is 90% chance. Second, androphonium test. Just the test that we saw. Yes, directly IV androphonium જોઈએ અને એમાં આપણે જોઈએ તો 60 to 95% it will be positive in ocular and 70 to 95% in generalized myasthenia gravis. Generalized means involvement of the all limb muscles also together with just the muscles of the eyes. Repetitive nerve stimulation, also termed as RNS, that is, you stimulate one nerve continuously again and again, again and again. You try to stimulate the nerve externally, like ES, electrical stimulation. Current આપીએ. Same way, you try to stimulate the nerve again and again. 20 શું થશે? Nerves માંથી તો acetylcholine release થશે, પણ muscle માં response નહીં આવે. Why? Because receptors are decreased. So it has sensitivity of 10 to 17% for ocular and 53 to 100% for generalized. Because peripherally, peripheral nerves માં તમને guaranteed ખબર પડી જશે yes, this is myasthenia gravis or not. Single fiber EMG, that is doing EMG, say for example, this is one muscle, yes, which has all the fibers. Yes, say for example, this is the biceps muscle that you are talking about. Here, all the fibers, instead of doing for all fibers, you select one fiber and you insert one needle EMG. And you try to stimulate that muscle. Yes, so there are chances for ocular muscle, it will be specific to 80 to 92%, and similarly for generalized myasthenia gravis. And ice test is specifically used only and only for ocular myasthenia gravis. Generalized માં એટલું બધું response નહીં જોવા મળે, so it is not that sensitive. Imaging. Why is imaging needed? Chest X-ray. Involvement of lungs. To check for it, we do chest X-ray. Frequently performed at any point towards alternative diagnosis like Lambert-Eaton syndrome due to lung tumor and comorbidities. Any other comorbid? Additionally, any other condition the patient has. Yes, for the lungs, pulmonary asthma or pulmonary chronic obstructive lung diseases. All these are comorbidities along with the myasthenia gravis that will lead to furthermore decrement in the patient's condition. It may also identify widening of the mediastinum suggestive of thymoma. Yes, thymoma, involvement of thymus gland, as we have already talked, the fourth and the most important pathophysiology that is called as the involvement of thymus gland. CT and MRI are more sensitive ways to identify the thymomas. Yes, MRI of cranium and orbits may also be performed to exclude compressive inflammatory lesion of the cranial nerves and ocular muscles. Now we need to get clear that there is no involvement of brain or any other meninges as the whole, the head. Yes, so if anything as such is seen in CT scan MRI, then it is not myasthenia. But if it is not seen and we see only the involvement of ocular muscles and lower cranial nerves, then we can say yes, this is more of myasthenia gravis and not any other condition. Pulmonary function test can also be done, which is also termed as PFT. You might be learning in cardiorespiratory function. So spirometry, yes, lung function testing may be performed to assess respiratory function if concerns exist about the breathing adequacy. The forced vital capacity, that is forceful expiration following a forceful inspiration. That is forced vital capacity. एकदम force की अंदर सांस लेना and to blow it out as much as possible. That is forced vital capacity may be monitored at intervals to detect increasing muscular weakness. So this will tell you if all the muscles, may it be primary or accessory muscles of respiration, are working or not. Severe myasthenia may cause respiratory failure due to exhaustion of the respiratory muscles. So if respiratory muscles do get involved, that will lead to ultimately severe myasthenia, may even lead to ventilatory support and death later on. Okay. We'll keep it till here, till pathological findings we'll see in the next lecture, and then also we are going to see the management. Yes, management is short for myasthenia, will not take much time for it. Yes. Okay. Any doubts in all the things we have discussed so far? Starting from classification today, we saw class 1, class 2, 3, 4, and 5. 2, 3, 4 are only based on mild, moderate, and severe involvement. And furthermore, A and B of the same 2, 3, and 4 is divided for which muscles are involved. May it be bulbar or respiratory or limb or axial muscles. Yes. After that, we saw about the physical examination. For physical examination, we ask the patient to look at a specific point for a prolonged period of time to check the fatigability of the eye muscles. We ask the patient to look at the foot when they are lying supine. Keep the arm stretched forward for 60 seconds. 10 knee bends, walking for 30 steps on both toes and the heels. 5 sit-up, lying down supine, giving the rest, and again sitting up again. So that will tell you the patient has fatigue, relief, or not fatigue. Blood test can also be done with protein antibodies and to differentiate from Lambert-Eaton syndrome. That is most important. Lambert-Eaton is a pre-synaptic disease. Myasthenia gravis is a post-synaptic disease. That is the only difference you need to remember. Electrodiagnosis, RNS, and surface EMG. SFEMG, surface EMG can be done. Eyes test, as we already described, this is the eyes test, and this was the sleep test. Endocorneum test, applying the neostigmine directly and checking for the patient response. And diagnostics test, which are more sensitive. So you can say to diagnose a generalized EMG, always go for RNS. Yes. EMG, NCV, and RNS. EMG, NCV, RNS. This is totally together also termed as nerve conduction studies and should always be done by an MPT specifically in neurological condition. It is one of the forte or you can say scope of doing MPT in neurological condition. You know how to operate these conditions and how to interpret the results of such NCS, that is now conduction studies, which also involves EMG. Imaging can also be done, chest X-ray and CT and MRI can be done to rule out other conditions. There is no specific way to say this is myasthenia from imaging. It is just to rule out other additional conditions or comorbidities. Pulmonary function test can help you diagnose and see for the respiratory muscle involvement. That is more important. Pathological findings we will discuss in the next lecture. Okay. Any doubts till now you have? Please reply with yes or no in the chat. Okay.